The topic here is going to be electronic fetal monitoring. Now, if you've ever worked in an L&D ward, especially in the United States, you will know that this is done practically universally. And so the USMLE is going to expect that you know this, and they will give you a question on electronic fetal monitoring. More than likely, they'll give you a strip, which will show heart rate and contractions, and you will be expected to know whether it's normal or abnormal, and if it's abnormal, what is the pattern and what is the cause behind it. Okay, so this is very high yield for USMLE. If you haven't yet, please subscribe to my Patreon page at www.patreon.com/pwbmd. I give you a link below, and then you can also click on the I on the upper right-hand corner of the video. Chip in $1 a month, little tiny bit goes a very long way in helping keeping these videos free. If you like these videos, I've been putting them out for about 4 years now. Please consider subscribing. It really helps out. Thank you very much. All right, so what is the purpose of electronic fetal monitoring? Basically, it's to assess fetal well-being during labor. Now, there's a little bit of a problem with electronic fetal monitoring, and that is, while it tells you very well that the baby is doing okay, it's very good at that, it doesn't necessarily tell you definitively that the baby's not doing okay. In other words, there's a lot of false positives. So you may get a strip and it's not technically reassuring, or there's abnormalities to it, but that doesn't necessarily mean that the baby's not doing okay. Okay, so that's why we use the term reassuring and non-reassuring. Now, a lot of authorities are saying we should phase these terms out, but I like them because reassuring means it's reassuring. Non-reassuring doesn't mean it's bad or ominous or concerning. It just means that we can't be reassured, okay? So there are some differing opinions on some of the interpretations that we're going to see here and their importance or correlation with the outcome, just because we have such a high false positive rate. However, most seem to favor the practice of routine electronic fetal monitoring. It's very commonly done in this country. So you can see here that there are 2 of these straps around this woman who is in labor. This first one is a uterine tachometer, and that is a device that measures the contractility of the uterus, and that's going to be related in terms of millimeters of mercury. This down here is called an external fetal heart monitor, called external because there are ways that you can monitor the baby's heart rate internally by placing a scalp electrode. But this is much more commonly done, and this measures the baby's heart rate in terms of beats per minute. So you put these 2 together, cardiotachometry. This is an old antiquated term, but I like it because it tells you in one word exactly what you're doing. You're measuring the heart and you're measuring the pressure, namely the pressure of the uterus. So you put these together and you get this strip, okay, where you've got the baby's heart rate, you've got the pressure of the uterus. And this is what's going to give you that strip that will tell you if there is possibly something wrong, or if we can be reassured. So we're going to talk about 4 different things. The baseline fetal heart rate, pretty simple stuff, but there's a lot of differentials behind bradycardia and tachycardia if it's abnormal. Variability, which is a unique sort of concept behind electronic fetal monitoring. Accelerations, which are very reassuring things. We like to see those. And then decelerations, extremely high yield for USMLE. A lot of times they'll just give you a deceleration pattern, ask you what kind of deceleration is this, and if you know that, it's a very easy point on the test. So normal fetal heart rate is between 110 and 160 beats per minute, obviously much different than the normal heart rate for an adult, which would be roughly 60 to 100 beats per minute. And then contractions, there's varying definitions of what normal contractions are for labor, but usually 3 to 5 per 10 minutes is going to be your normal contraction pattern, and they should last at least 30 seconds apiece. Now, just point out here, these vertical lines are each 10 seconds. Okay, so You know that. Kind of like an EKG. You got to know how long each of the boxes are. And then we talked about the Montevideo units in the previous talks on labor and delivery. It's accepted that 200 Montevideo units are necessary for normal labor progression. Okay, so go back and refer to those videos if you don't know what a Montevideo unit is. So as mentioned, the normal baseline fetal heart rate is 110 to 160 beats per minute. Now, a baseline means that we're looking at where the heart rate tends to hover around, where that heart rate hangs out. You have to exclude accelerations and you have to exclude deceleration. So you're looking at what it's normally sitting at most of the time. And it doesn't have to be perfect. Okay, we usually round it to the nearest 5. So 140, 145, 150. And if you're not perfect, that's fine. But you want to have an idea of if there's bradycardia or tachycardia present, and typically that's pretty obvious. So the differential for bradycardia and tachycardia can be pretty broad. The way to think of this is that there are a couple normal causes, and then you can divide it up into maternal factors, so things going wrong with mom, maternal-fetal interface, so the placenta and cord, fetal factors, things wrong with the baby, and medications, things that mom is taking that can affect the baby. So for bradycardia, fetal sleep is pretty common. Probably not during labor so much, though. So if you're doing if you're doing an auscultation with the Doppler and listening to the baby's heart rate and mom's in the clinic, baby could be sleeping. Probably not sleeping during labor so much. I mean, you've got all those contractions. You know, if I put a vice up to your head and contract your head, you're probably not going to sleep too much either, right? Okay, so some of the maternal factors. Supine positioning kind of goes along with hypotension. Why? Because when the baby's head is sitting on top of the inferior vena cava, it's going to reduce the blood flow back to the heart. That's going to reduce the cardiac output and hence reduce the blood pressure. Hypoglycemia can also cause bradycardia in the fetus. At the maternal-fetal interface, poor uterine perfusion. This is very, very bad if this is happening. And umbilical cord prolapse, also a big complication, obstetrical complication. Fetal factors can be things like arrhythmia. So what kind of arrhythmias? Congenital heart diseases, conduction defects, anatomic defects. One of the more commonly tested conduction defects is the congenital heart block, which can be associated with autoimmune diseases in mom, particularly the anti-Ro and anti-LA antibodies. That causes a congenital heart block, goes away after the baby's born. Okay, and then vagal stimulation. So this is going to be the big cause behind your early deceleration, which we'll talk about in a little bit. Medications, these are things that cause bradycardia in everybody. Opioids, anesthesia, that can include local anesthesia, magnesium sulfate, and beta blockers. What about tachycardia? One of the normal causes of fetal tachycardia is just fetal movement. So if you go outside, move around, exercise, your heart rate's going to go up. Same for baby. Maternal factors, one of the more common ones, stress and anxiety. Mom's heart rate goes up, increases the blood flow to the baby. Baby's heart, to compensate, goes up. Fever and infection. It causes an increased heart rate in everybody. If you've ever seen a really sick, febrile person, their heart rate is typically elevated. Thyrotoxicosis, anemia, and hypoxia. These are things that cause tachycardia in everybody. The maternal-fetal interface, chorioamnionitis, often accompanied by fever and infection. Abruptio placenta. Fetal factors, arrhythmia and anemia and acute blood loss. What kind of arrhythmia? Things like supraventricular tachycardia, for instance, abnormalities with baby's heart. Anemia and acute blood loss, you think about it, that makes sense. Baby has reduced volume, needs to compensate by increasing the blood pressure, does that by increasing the heart rate. Medications can be things like anticholinergics. Benadryl, very commonly used drug, has some anticholinergic activity. Sympathomimetics and illicit drugs, for instance, cocaine, amphetamines, etc. So you look at the heart rate and you think, well, it's abnormal, so there must be something wrong. Well, not necessarily. Usually an abnormality of the baseline fetal heart rate, bradycardia or tachycardia, is totally benign as long as it's not very severe and there's good variability. So we'll look at what variability is in a few seconds here. So just look at this strip and try to figure out where the baseline heart rate is. You can see that there's variability. Just a little preview of what we're going to talk about. But can you gather where the baseline is? So you look here, these lines 30, 60, 90, 120, 150, 180, 210. And it's about right here, okay, roughly. And that's about 130 beats per minute. So one line above 120. Okay, so what is variability? You'll know variability when you see it. The definition is kind of obscure. So the technical formal definition of variability is a fluctuation of the baseline in amplitude and frequency of 2 cycles or more per minute. Okay, that isn't really useful to us. So let's just look at this from a practical perspective. So variability is kind of like what you see here. Okay, it's not just a straight line. There's movements around here. And so if you didn't have any of that, if it was just a straight line or a moving line, very smooth line, that would be absent variability, totally undetectable. That is non-reassuring. That's not good. You never want to see that. Low variability means that it's less than 5 beats per minute. So the only changes you have from baseline are less than 5 beats per minute. Moderate variability is a broad definition here. It's between 6 and 25 beats per minute. Most of the time, most strips, if you look at them, the vast majority will be moderate variability. This is reassuring. And then marked variability is more than 25 beats per minute fluctuations, and this can be associated with fetal hypoxia. Where does variability come from? Why is the fetal heart bumping all around here? And the reason is because there's interplay between the sympathetic and parasympathetic nervous systems. Now, some of the causes of decreased variability are things that are going to kick up your parasympathetic nervous system, and so you'll lose variability in that regard. And so for that reason, a lot of times when we see absent or very low variability, the baby tends to be bradycardic. So these are things like CNS depressants, morphine, Demerol, Stadol, alcohol, things that mom might take. In baby, it can be when they're sleeping. Parasympathetic nervous system is really going to be kicked in during sleep. CNS anomalies like anencephaly, hydrocephaly, hypoxia, cardiac anomalies, etc. So typically we tend to see reduced variability when you're either bradycardic or tachycardic. Just kind of a rough rule of thumb. Okay, so what is this back here? Well, if you look kind of these fluctuations, this is all baseline here. This might be a little acceleration, but if you look here, we're all the way down to about 125 here, and all the way up to about 135 here. So what kind of variability is this? This is moderate variability. Okay, so you can see here the difference. This is marked variability, so there's really no accelerations. If there are accelerations, they're going to be kind of covered up. But really, we don't see any discrete accelerations here, so you're going everywhere between, well, I think the author here just meant to demonstrate this, so we're not going to look at the heart rate, actually. Like they covered it up, too. So you can see moderate and minimal are pretty close together. Not much consequence there, though. This is moderate here, anywhere from 6 to 25. And then minimal, obviously much flatter, much smaller sawtooths in the curve here. And then absent variability, just kind of straight line, might move around a little bit, but there's no fluctuations like what we see in minimal and moderate. Okay, what are accelerations? You heard me talking about these a little bit already. Accelerations are periodic increases in the fetal heart rate of 15 beats per minute sustained for at least 15 seconds, but no more than 2 minutes. If it's more than 2 minutes, then we consider that a change of baseline. So you'll hear this 15 by 15 all the time. That's an acceleration. So an increase in the fetal heart rate of 15 beats per minute at least for at least 15 seconds, and then returning back to what our baseline was. This is always reassuring. This usually coincides with some kind of fetal movement or stimulation. This is always, always good. We always like to see accelerations. As a matter of fact, when you do the non-stress test, if you're assessing fetal well-being outside of labor, accelerations are actually what you're looking for. And if you have more than 2 accelerations in 20 minutes, that's considered a reactive stress test. Okay. So where are the accelerations here? You can see there's uterine contractions, but no decelerations. But where are the accelerations? There's one here, and there's one here. So remember that each of these vertical lines is 10 seconds. So you're going from baseline probably about 135-ish, going up to 160. So that's 25, a change in 25 beats per minute. And it's lasting about 25, 30 seconds. Now, these accelerations may coincide with contractions, or they may be independent of contractions. If they coincide with contractions, we call that a periodic acceleration. If they are outside of the contractions, we call that an episodic acceleration. It doesn't really make much of a difference. We like to see accelerations. They're a good thing. Okay, so looking even closely here, you see these 2 accelerations. You see a periodic one here and an episodic one here. Okay, this is big, big, big stuff for the USMLE. You need to know this. Decelerations. So this is where you will see some major problems if you have some of these decelerations. So deceleration is a drop in the fetal heart rate of more than 15 beats per minute with an onset to nadir of more than 30 seconds duration. And when I'm giving you this definition here, the ones that apply are early and late. Variable is kind of its own animal, and we'll talk about that in a couple minutes. Okay? So early decelerations are inconsequential. Early decelerations are caused by vagal stimulation because of compression of the fetal head. So the head is down there, there's the uterus around it, the head, or the uterus compresses the head, and that's going to cause vagal stimulation. Remember that the vagus nerve, it's a cranial nerve, goes and innervates the SA and AV node, and when you have vagal stimulation to those nodes, it reduces the heart rate. And that's all you've got happening here, vagal stimulation. You can vaguely stimulate yourself and cause an early deceleration in yourself. Go rub your vagal nerve. It's going to reduce your heart rate. That's exactly what's happening in the baby. For this reason, it is inconsequential because it's a normal reaction to having something pressing on your vagal nerve. So yes, it's due to head compression, but it doesn't necessarily mean that there's anything wrong. Okay, so this is inconsequential. Early decelerations here. And so here we see early decelerations. Now note that the early deceleration, this is so important. Early deceleration coincides with the uterine contractions. It starts with the uterine contraction and ends with the uterine contraction. The bigger the contraction is, the larger the deceleration will be. And a lot of times it's about 30 or 40, a drop of about 30 or 40, but it can be less if the contraction is weaker. It can be more if the contraction is stronger. Okay? So very, very, very important that you know how these coincide with one another. Early decelerations are mirror images of the contractions. Okay? See that here? They start with the contraction and end with the contraction. Now, variable decelerations. This is tricky. Variable decelerations are very tricky, and it's very easy to confuse these with late decelerations. So, variable decelerations are decelerations that are variable in relation to the contractions. Now, that is a good definition, but it doesn't really tell us everything. And if you only know that, it can be very easy to confuse these with a late deceleration because some of the decelerations in the variable decelerations look almost identical to late decelerations. So one of the things that's going to help you with variable decelerations is understanding that this is an abrupt change in fetal heart rate, where the early decelerations need to take at least 30 seconds to go from baseline to nadir, the lowest point. The variable decelerations will do that much, much, much more quickly. Okay, usually maybe 10 or 15 seconds. So these are abrupt changes in the fetal heart rate. And they may last longer or they may not last as long. But they're abrupt changes when they happen. They're abrupt drops in the heart rate. Variable decelerations tend to be U, V, or W shaped. They tend to be more jagged and more irregular. Look at our early deceleration. Very smooth and gradual. Now, let's look at the variable deceleration. Much more abrupt, a much faster drop here. Look, from onset to nadir, less than 10 seconds. And it can be much, much, much more dramatic. Look at this drop. Baseline of about 150, drops all the way to 90. Okay, so very, very, very abrupt and significant drop. And also look, they're variable. No one deceleration looks the same to the other. They're also variable in relation to the contractions. No real apparent relation to the contractions. However, they do relate to the contractions. Okay, they are related to the contractions because they're related to cord compression. And the pathophysiology of the variable deceleration, why it happens physiologically, it's very complex, and it has to do with reflex tachycardia and baroreceptors and all that stuff you do not need to know for the test. But you do need to know how variable decelerations look, that they are abrupt drops in the fetal heart rate. They can be dramatic drops in the fetal heart rate, whereas with early and late, they're not quite as dramatic. And they're very different looking from one to the next. But there's no apparent association, just looking at the strip, no real apparent association with contractions, even though they are caused by the contractions. Now, when we look at variable decelerations, there's ways that we can categorize this. And this is really only important because there are two possible causes of the variable decelerations, or at least two implications. Okay, so you can divide this into mild, moderate, and severe variable decelerations. So a mild variable deceleration is where the drop is between 15 and 40 beats per minute. So if you look at this one here, you're going from 150 to 120. That's a mild variable deceleration. A moderate variable deceleration is a drop between 40 and 60 beats per minute. So that would be one like this one here. Baseline of about 150, drops to about 90. This is a moderate variable deceleration, but if it got any lower than this, then it would be a severe variable deceleration. And that is where you have a drop of more than 60 beats per minute. You'll want to know the definition of a severe variable deceleration, because a severe variable deceleration may be an indication of fetal acidosis. And while the mild and moderate variable decelerations are inconsequential for the most part, a severe variable deceleration, where you have a variable deceleration with a drop of more than 60 beats per minute, or if the drop causes it to go below 70 beats per minute, that is a severe variable deceleration, and that is associated with fetal acidosis. And that would render our strip to be non-reassuring. Okay. So again here, variable decelerations, very abrupt drops and very significant drops. Now, what kind of variable deceleration is this? These are severe variable decelerations. Look how far down it's going. This heart rate is going all the way down to 50 beats per minute. And the baseline is about 120. So not only are you dropping by 70 beats per minute, one definition of a severe variable deceleration, but you're going below 70 beats per minute. And so this is a significant drop. So you're dropping more than 60 and dropping below 70. But you only need one or the other to be a severe variable deceleration. So this is a non-reassuring fetal heart strip. Okay, now if you didn't have these, let's say you only dropped a little bit, and you had early decelerations, for instance, that were coinciding with these contractions, then in that case it would be reassuring. Okay, because early decelerations are not uncommon, they're not non-reassuring, they're inconsequential. But these are severe variable decelerations. Now, you might confuse it with a late deceleration. And let's look at late decelerations. So this is a late deceleration. Now, one of the things that's going to help you differentiate a late deceleration from a variable deceleration is how gradual a late deceleration is, first of all. Okay, very gradual. It's not an abrupt drop. Okay, from onset to nadir is much more than 30 seconds. But also how shallow it is. You don't have a real significant drop in heart rate. So baseline here, about 135, dropping to about 115. Okay, only a drop of about 20 beats per minute. Very rarely do late decelerations drop more than 30 beats per minute. Usually it's around 5 to 30 beats per minute. And they're very long and they're very shallow. Okay, so they look like early decelerations. They don't look at all like variable decelerations. However, what helps you distinguish them from early decelerations is quite simple. Whereas with an early deceleration, the drop began with the compression. With a late deceleration, the drop came after the contraction started. Okay, so early deceleration began with contraction, late deceleration begins after the contraction. And the early deceleration ends with the contraction. A late deceleration ends after the contraction. So it starts after the contraction and ends after the contraction. It's shallow and it's gradual. That's a late deceleration, and late decelerations are bad. Bad, 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 bad. They are a sign of uteroplacental insufficiency or borderline oxygen supply to the fetus. Okay? Always non-reassuring. We never like to see these. This is probably the worst thing you can see on a fetal heart strip. Okay, so we're going to just allude to the pathophysiology behind late deceleration, and I just want to show how it's different from the early deceleration, why late decelerations are late and early decelerations are early. So when the uterus is contracting, it reduces the blood flow to the placenta. So here's a contraction, right? We're starting out baseline, or a basal pressure of 10 millimeters of mercury, contracting up to 60 millimeters of mercury. Okay, so this is our contraction here. And during the peak of the contraction, you actually have a temporary pause of blood flow into the uterus during the contraction. And you can correlate that to the placenta, because if you're not getting blood flow to the uterus, it's not going to get to the placenta. It's not going to get to the baby. So this is okay. Okay, during contractions happen, you have interruptions of blood flow to the placenta, and that's okay. The problem is going to come when there's already issues with blood flow to the placenta. So if you already have an inadequate blood flow to the placenta, and now you have a contraction, this gray area here is going to be wider because you already have inadequate flow. And so it takes much less pressure in order to pause blood flow to the uterus. And so these babies, when there's contractions, the blood flow is going to be paused for a much longer period of time, and they are going to be predisposed to developing hypoxia. Okay, so this is the pathophysiology behind a late deceleration. Note all of the things that have to go on. You have decreased oxygen delivery to the fetus via the placenta. It causes hypoxemia and acidosis, and that's going to elicit a parasympathetic response and myocardial depression, all of which eventually cause deceleration. Key word there is eventually. It takes a long time for all this to happen. That's why it's a delayed process. It's a late deceleration. It doesn't happen right away when you get a contraction. It happens a while after. It takes time for you to become hypoxic. It takes time for you to become acidemic. So the deceleration is also going to be delayed. Now compare this to an early deceleration. All it is head compression causing vagal stimulation, causing parasympathetic input, causing deceleration at the heart. Very, very, very simple process. With late deceleration, it takes a while. There's a lag time to it. And that's why with a late deceleration, it comes after the contraction, or starts after the contraction starts, ends after the contraction ends. Whereas with an early deceleration, it coincides with the contraction. It doesn't mean that the contraction isn't causing it. The contraction causes both late deceleration and early deceleration. It's all caused from contractions. The difference is the pathophysiology of it. With the early deceleration, it's very simple. It happens very quickly. With a late deceleration, there's a process that goes on. There's a lag to it because all these things have to happen. You have to first develop the hypoxemia and the acidemia, and then it's got to trigger all these physiologic processes which finally result in the deceleration. The same thing for the recovery from the late deceleration. When the contraction ends and oxygen comes back, now you have to correct the hypoxemia and the acidemia for all of these processes to stop in order for the heart rate to go back up. So you can see with the late deceleration, it's so delayed because it's such a big physiologic chain going on. With early deceleration, you're just stimulating the vagus nerve. Very simple. Okay, so what is this? I'm just going to give you some strips here, and I want you to tell me what it is. Okay, so you see we have our contractions here, but really nothing going on with the contractions. So what's the baseline here? Pretty hard to tell. What kind of pattern is this? What kind of variability? This is marked variability. Note that we may have some accelerations here, but we don't really see them. But the variation, just going from one point to the next, you're hitting 180 relatively frequently. You're also hitting 110 relatively frequently. That's 70, a difference of 70 beats per minute. That is marked variability. Okay, what about this one? What is this? Okay, what's our baseline? Well, it's way up here. Baseline is about 200, maybe 195. So this is tachycardia. And what are some of the common causes of tachycardia? Maternal fever, maternal stress and anxiety. Some of the more ominous things would be like chorioamnionitis. So you look for prolonged rupture of membranes. Maternal fever would coincide with that in a lot of cases. All right. What about this? What is this? So where's our baseline? Well, it's about right here. So right around 140 or so. And what else do you have? Well, here's our contractions. What's going on here? So you have two things here. You have absent variability. Look, no sawtooths here to this heart rate. And then look at these dips. Where do these dips start? Well, if it was an early deceleration, it would start right here, right when the contraction starts. But look, it doesn't start until here. So you got about 10, 20, 30, 35, almost 40 seconds between when the contraction starts and when the deceleration begins. That is a late deceleration. And also note, look how shallow it is. The difference is only 140 to 120, or maybe 140 to 110. Not very much. Okay, if this were a variable deceleration, you'd be dropping much quicker. Okay, you'd be dropping down like that, and you'd be dropping down further in many cases. Okay, so absent variability, late decelerations. Very, very non-reassuring for both reasons. And this is pretty indicative of some kind of hypoxia going on. Okay, so remember that late decelerations associated with uteroplacental insufficiency, which is going to result in hypoxia and acidosis. And that's what we're most concerned with here. So this would be an indication to do some intrauterine resuscitation. Okay, what about this? What kind of decelerations are these? Your baseline here, about 130. I don't see any accelerations, but what do we see here? So where do these decelerations start? Well, the deceleration starts here, ends here. Starts here, ends here. Well, what about the contractions? Contraction starts here. Decelerations doesn't start till here, about 40-50 seconds later. This is late decelerations, non-reassuring. So just to review, what do we want? Ideally, if you have to pick out the fetal heart strip and you're delivering a baby, you want a normal baseline fetal heart rate between 110 and 160. You want to see accelerations every now and then. Accelerations are changes of at least 15 beats per minute up, lasting at least 15 seconds. You want to see moderate variability, 6 to 25 beats per minute, changes from the baseline. And then you don't want to see either you don't want to see any decelerations or early decelerations. Early decelerations are, they're not your friend, but they're not your enemy. They're neutral. They're not a big deal. Okay? What do we fear? Well, we definitely fear very severe or persistent tachycardia or bradycardia. Now, if you happen to hop up into 170 or 180 even, and you have moderate variability, that's okay. It's not a big deal. Okay, remember variability. If there's good variability, then it kind of negates some of that tachycardia or bradycardia. It's not a big deal if you jump into tachycardic or bradycardic territory for a little bit. Okay, that's okay. What we're concerned about is severe and persistent tachycardia or bradycardia. What else? Absent variability. Remember, absent variability is a sign of inadequate interplay between the sympathetic and parasympathetic nervous system. And so that is not a good thing. And then, of course, severe variables or late decelerations. Okay? So remember that those late decelerations, they're very ominous, and almost always they're an indication for a C-section to get that baby out ASAP, because it's better off having its own oxygen that it breathes in than relying on that placenta. Late decelerations indicate a placental problem, a uteroplacental insufficiency, resulting in a hypoxia and acidemia, although there can be other causes. So throughout labor, it's very important to monitor the fetal heart rate and ensure that the pattern is quote-unquote reassuring. Remember, the reassuring pattern includes a fetal heart rate between 110 to 160, along with adequate variability, moderate variability. Early and variable decelerations are normal, but severe variable decelerations and late decelerations are not normal. They're non-reassuring. Non-reassuring fetal heart pattern includes fetal bradycardia. Tachycardia, if it's very, very, very slight, tachycardia is not so much a big deal. If it gets beyond 170, 180, it's a much bigger problem. If there's a loss of variability, as we saw in some of those strips, or if there's repetitive late decelerations or severe variable decelerations, that's a big, big problem. And that's probably going to be your test question on the USMLE, showing you late decelerations. And I want to know, what do you do? So anytime you have a non-reassuring fetal heart pattern, here's what you want to do. You want to consider non-hypoxic causes. Non-hypoxic causes oftentimes can be reversed because they're not placental problems. So consider things like anesthesia, medications. These are things that can cause you to lose your variability. They're things that can cause bradycardia. Then do your intrauterine resuscitation procedures. So do things like discontinue oxytocin. Well, why would you want to do that? Well, think about it. If you have late decelerations, what's the cause? Well, the cause is that you're contracting and the baby is not getting enough oxygen because there's already problems with oxygenation. Well, then why would you want to give oxytocin? Oxytocin causes contraction. So you want to DC oxytocin. You want to give mom oxygen. If you're giving mom oxygen, you give baby oxygen. If mom's oxygen is low, baby's oxygen is going to be low. So you want to make sure that mom's oxygenating to the max, 100%. Change the position from supine. Well, that makes sense because we want adequate blood flow to the baby. If mom's blood pressure is low because she's got a low cardiac output, that's going to cause all the more problems for the placenta. So change the position from supine. A vaginal exam. Why a vaginal exam? Because one of the causes of bradycardia is what? you know this. One of the causes of bradycardia is a prolapsed cord. Okay, so that's why we do the vaginal exam. And then scalp stimulation. See if you can try and get that heart rate up. If the baby's head is already presenting, is engaged, you can feel that head. You can try scalp stimulation either with a tool or with your finger. And then at that point, after you do some of those procedures, you reassess the strip. If the strip continues to be non-reassuring, you can consider doing a fetal scalp pH assessment. You're just taking a little nick off the scalp, getting some of that blood, taking that blood back, checking the pH. If it's above 7.2, it's probably not a big deal. Remember, a lot of these non-reassuring fetal heart patterns, there's nothing wrong with the baby. It's just a non-reassuring fetal heart pattern. However, if the fetal scalp pH is less than 7.2, you're delivering that baby right away, C-section. And then, as mentioned, prepare for prompt delivery if normalization does not occur. And that's all I've got for you here. If you know all this stuff, you will get every single question right on electronic fetal monitoring that the USMLE can throw at you. Any questions, write me a note below. Otherwise, please remember, subscribe to my Patreon page. I really, really appreciate the support. And I will see you next time.